Hello and welcome to Pulse, your podcast delving into all things health, innovation, digital and data. Proudly brought to you by Pulse IT News. I'm your host, Louise Shaper.
And I'm your co-host, George Margellis.
George, before we get into the show, you need to explain to me what happens at Greek Easter.
Greek Easter is a big thing. So actually Greeks celebrate Easter much more than Christmas or any other event. And it's in Greece, it's like a national holiday for almost a week. Basically, this week is the last week of Lent, and theoretically there's church every day. Yeah, for most, not all. But come Friday, every Greek in Australia will be at their local church. We walk around the church carrying what we call the epitaphial, which is the burial shroud of Jesus Christ. It's a huge social event. So it's a very important event, and I'm not going to pretend to be a Greek priest hat, but socially, it's the opportunity to catch up with people you haven't seen all year. So it's a big social event, and then on Sunday we eat until we drop.
I was going to say, what's the food like at Greek Easter?
So much food. Some people have been fasting for 40 days. No animal products for 40 days.
Oh, wow.
My wife's trying to get us to do it for a couple of days with mixed success.
So you're vegan. Is that what's happening?
Basically, yeah, you become purely vegan. So no animal products. Some people do it for 40 days. Some people do it for the 7 days before Easter Sunday. They talk about it as being a very cathartic thing because obviously, yeah, it's a good health initiative as well. Maybe I'll try and tie up a longevity startup around Greek Easter as a new option.
You could.
And in Greece, like all the families leave the cities and go back to the village and have big family events. And it's quite fun. When I was in Greece earlier this year, it was the beginning of the 40 days. So I don't know if I mentioned it in my last podcast, but they have a great big carnivale type thing at the end of the period before Easter. So again, things go wild there. There's big celebrations. And so it's a very festive time.
Oh, that sounds like so much fun. And do you wear like your best suits and that sort of stuff?
In the good old days when we were single, we dressed up because that was where young Greek boys met young Greek girls. My boys are getting dressed up. The idea is you really have to get dressed up, and you wear mourning type clothes on Friday because that's the death of Jesus. And then you have to wear bright red and celebratory clothes on the Sunday. So it's really quite a big event.
Oh, cool. You have to send me some pictures of the family.
If you get a chance, just jump by your local Greek church on Saturday night and join the festivities. The more the merrier.
It sounds fun. That's cool. Because yes, when this episode lands in everyone's inbox, we will be in the midst of the Easter long weekend. Yeah, but you've been in Singapore recently. So tell us, how did that go?
I have. So I flew off to Singapore for the Aging Asia World of Aging event, which is a big regional event focusing in on aging, and not just sort of aged care, but the whole process of aging and how it relates to people. And I have to admit, Singapore, to their credit, is doing some very interesting work around how they accept aging into their society and what they do about it. We had a cheer squad of 60 people over the age of 70 starting off the event, just to show that you can actively age. And Singapore is very big into active aging. They actually have a whole bunch of active aging centers. So they set up these places where people get together, do exercises, communicate. So some interesting stuff. It was a big event. I mean, lots of people there. I do have a bit of a bugbear about some of these events in that, they have a whole bunch of presenters, and each one of these presenters started off spending 5 minutes defining aging problem and showing the same graph, 1,000 times. Did you know that we're an aging population? So they go, we're at the world of aging. I'm pretty sure we know that.
You see that all the time. Let's look at these demographic changes. And it's like, no. You're not, if you're in an event, I don't know, for accountants or something, then maybe, they need an update on what's happening demographically. But yes, you see that stuff happen all the time. So, okay. So that took a third of the conference away then.
Yeah, that took a whole bunch of things away. Like I said, I've got these graphs of aging society pressed into my retinas now as a result of that. It wasn't purely a technology event, but there was a lot of talk about technology and innovation. And they did have a very big award ceremony. The problem is, and this may well just be because we've been doing this for so long, but the innovations they were showing were the same innovations we saw 20 years ago. So remote patient monitoring, fall detection, all those sort of things. Now, the difference is they work better now than they did back in 2006 when, my friends at Intel were working on them. And that may well be because of Moore's law. The computing power is now 1,000 times better than what it was then. But I have to say the Australians did particularly well. So 2 Australian companies, Lenexa Medical, they won the Innovation of the Year for their smart mattress technology.
So what does the smart mattress do?
Basically, it's like a sheet they put over a bed, which has a whole bunch of sensors and stuff in it that picks up vital signs, movements, and they use it for basically monitoring people in bed, in particular in aged care beds where people need to be turned every so often. It picks up when people are moving so they can determine the best optimum time for do turnings so people don't get pressure sores, captures vital signs like pulse and temperature. It's quite interesting technology. It comes out of research down in Melbourne from what I understand, and they did quite well. There was this booth there. And their technology was quite impressive. I mean, I have seen it a couple of times, but it seems to have progressed. And they've actually now managing to market it in Australia. I have to take my hat off to Austrade. Austrade did a good job in having an Australian booth and promoting Australian product there.
Oh, that's good. So on that mattress thing, have you heard of 8 Sleep?
8 Sleep.
8, like the number 8, but in letters, and sleep. So I heard about it on a podcast and I was like, oh, I want one of those. Well, I don't have one because I'll tell you in a minute how much they are. But yeah, it's like this cover that goes over your mattress and it does all of that stuff. But they're promoting it as a longevity thing. So you'll get like the best sleep you've ever had in your life. If you're at a certain age, ladies, and you get a little hot in the evening, the mattress actually picks that up and adjusts the temperature. So it actually cools you down. And then if your partner is snoring, it'll pick up on that and actually move him like automatically. And I'm like, oh my God, I so need one of those. Well, I don't have one because they're $6,500. But like they've been in America for ages. They must be making money.
That's what we said about 23andMe too. Let's not go there.
Oh, okay.
Does it pick up the pillow and put it over their face, or is it stop? If not, if so,
that's
please
not
don't.
in the promo video. But
Okay. Just in case, don't send the information to my wife. Just in case. Look, the other company was a company called Silver Adventures, and they spell silver without an E because obviously the word Silver Adventures with an E must have been taken by someone else. And they do a VR goggle type solution which enables people with dementia to understand more about their disease, but also share with them images about where they used to live and other places they want to go. And they won the best technology innovation by an operator. So they're doing a project in Singapore with St. Luke's Elder Care. And so they're basically integrating it into their elder care solution. Now, again, St. Luke's is one of those big aged care providers over there. They have an active aging center. So they're using this tool sort of as a supplementary tool to help people get through some loneliness issue, get through some social isolation issues, just give them an opportunity to see different parts of the world. And I think it was a nice tie-in that I've known Colin, who's been working on this for a while, and it just shows that the persistence in startups and the ability to pivot how you use your technology makes a big difference. So they started off very much as a, educational tool using VR, but then they sort of realized the differences in the market and doing quite well over in Singapore.
oh, well, that's great. Oh, good on those 2 companies. And yeah, we'll put links to them in the show notes then as well.
How's your last fortnight been over here in Melbourne?
Well, I have been in Melbourne. I haven't been travelling, and I'm quite concerned when I open up my Qantas app, there are no flights booked. I'm like, oh no, who am I? But yes, I do have a travel plan, just hasn't been booked yet. But now I'm at home for a while, which has been great. And actually my big personal news, I was very excited. I'm always bitching, as Pulse Potties know, and you know, George, that I can't get a GP to use the My Health record, despite what I do for a living. I found a new GP, female GP, not too far from me. Like it took me about 7 minutes to walk to her. And I didn't even have to ask. She just automatically, when I was saying, oh, these are the things I want to talk about, she was like in the My Health record. I got the notification on my phone. It vibrated. And I picked it up and it was like, this GP is in My Health record. And I'm like, excellent. I'm not going to say her name because even though she deserves kudos, I don't want other people booking her up because she's quite busy and it took me a while to get in. But I will thank Dr. Chris Pearce, who many people, especially in the Australian health informatics community, knows Chris Pearce. He was the one who, when I was bitching to him that I can't find a GP who will actually take digital seriously. And I know there's lots of them, of course, but most of them are my friends. So it would be weird to go and see them. So looking for somebody I don't know. And Chris suggested this woman and she was amazing. And she actually was really helpful as well. Had the neatest handwriting I've ever seen and gave me all this homework to do. So I'm getting my stuff together. Yes, I've got information now in the My Health record. I'm very excited about that.
We should have logos for doctors. I use My Health record on the front of their practices.
Oh, definitely. And my sister, because of the complications with my dad's medical stuff, which I've talked about before, so it's very complicated. And, mum is like, well, I don't know, should he be on this drug or should he not? Or what's the list of drugs he's taking? My sister, who's not in this space at all, was saying, Louise, we need to penalise doctors somehow. And I'm like, what are you talking about? She said, well, if they're not using these systems that are made available to them, then they should be penalised. Like she even went to the extreme of saying maybe we should report doctors who aren't using it. I would not support that. But I love the fact that I've talked to my family so much about digital health. They're saying the things I want to hear. They're getting on board. They're drinking the Kool-Aid.
Were they talking about incentives and bundled payments? And once you've got your family talking like that, then you're really in trouble. Then you've gone too far.
That's right.
That's good to hear because, like I said, those sort of solutions are what's going to make the system scalable. So,
yes.
Kudos to your doctor and any other doctors listening. You'll get more patients like Louise. What more could you ask for? So go for it.
That's right. And we will promote you on the pod. Let us know. All right. Well, let's get to our hot topics, George.
Let's jump in.
For our first hot topic, we're delving into the world of AI advancing medical research. And by the way, I would just say I'm quite proud of myself. This is the only AI heavy story in today's pod because it's hard to find stories that aren't 100% AI. But anyway, so world of AI advancing medical research. So as reported in Pulse IT, Australian researcher Dr. Heidi Mulberry from the University of New South Wales Centre for Big Data Research in Health and the Centre for Healthy Brain Ageing, she has won an NHMRC Ideas Grant to use artificial intelligence to explore potential causal links between infectious diseases and dementia. Firstly, congratulations, Dr. Mulberry. George, I'm up for anything that prevents or delays dementia, but you're the one here with a medical degree. Can you explain what's this theory about linking infectious diseases and dementia?
Sure. So first of all, congratulations to the University of New South Wales, my original alma mater. So they're doing some great work over there. And I know the Centre for Big Data Research and the Centre for Healthy Brain Ageing, those sort of combinations of a technology group and a clinical group together to find solutions is really exciting. Look, this all came about because last week there was a big study came out from, of all places, Wales, where they found that people who had the shingles vaccine had a lower dementia risk. Now, this caused a whole bunch of controversy and discussion. And it's that classical correlation versus causation type discussion that we often have in healthcare, that things correlate, they don't necessarily are causative. But the concept is that infections like shingles, which is return of the chickenpox virus that lays dormant in your neurons for decades after your initial infection. So most people have had chickenpox or been subjected to it at a young age. The virus lays dormant in the ends of your nerves and 50, 40, 60 years later pops up again with a very painful rash, which is extremely debilitating and has some significant health consequences, especially if it's someone who's already has frailty and other comorbid issues. So when you look at that, this idea that preventing that reflare up or preventing infections in general can lead to decreased risk of dementia shows some good correlations. So people who have less infections tend to have less dementia. Now, does that mean that people who are very careful about their health and therefore avoid infections also tend to do other things that make them a lower risk of dementia? It's a really complex space in that no single disease like dementia has a single causative agent. There are some diseases where, specific genetic defects are causative, but they're few and far between. And the reality is everything in medicine is really, really complex. And now as we're starting to go down to, cellular level and genetic levels and intracellular organelle level and the mitochondria, which is a teeny weeny little organelle inside a cell, has been shown to have significant effects. We just have to make sure that we don't try to oversimplify things and make it seem too easy. So avoiding infections is generally a good thing. And we've seen the recent outbreaks of measles in the United States. So vaccines, despite what the Secretary of Health may say over there, are a good thing and they make a big difference. And if you look at what the effect of those has been, is that less people die of infectious diseases at a young age. And people have then sort of turned around and sort of said, oh, yes, but we have more dementia in an old age. Well, that's because more people get old because they didn't die in a young age. So it's a bit of a progression here. But I think AI can play a really important role here too.
Yeah, because all the data that it can go through so much faster than humans ever can.
We are talking so much data. That's right. But the reality is, most of these diseases sort of subscribe to that old Swiss cheese model. Multiple things have to happen at the right, or you could say the wrong time to lead to the end disease state. And understanding each of those and trying to manage them all is hard. And ultimately, then it comes down to some pretty simple things. Yeah, eat well, exercise, sleep well. Those sort of classical things that go back centuries are still the key for one thing. The other important thing here is because we talk about infection causing dementia, but there's a whole other hypothesis that goes around at the moment called the hygiene hypothesis, which suggests that reduced exposure to microbes and parasites, particularly during childhood, may contribute to the rise in autoimmune disease. So we can avoid infections and get autoimmune disease, or we can so it's really, really hard. At the end of the day, vaccination does work. Avoiding those avoidable infections through vaccination, not walking into a pit of people with infectious disease, wearing a mask when it's relevant. All these sort of things make a little bit of help, but understanding the complexities is still a long way away from us understanding them all well.
Yeah. And I believe that the shingles vaccine, at least in Australia, there is an eligibility criteria that you need to meet. So I think in some places you have to be like 65 and over, but you can be younger if you've got certain risk factors.
Yep. Speak to your GP, find out whether you're eligible. Over 65s, get it for free from across the country. Various other criteria get eligibility to it. It's not a cheap vaccine, but then having seen people with shingles.
Sounds like it's a good idea, even if it turns out it's not a causal relationship with dementia. It's just a good idea because no one wants shingles. Yeah.
Absolutely. Like I said, I've seen the consequences of shingles in elderly patients can be quite devastating.
I actually know someone who had it in her 30s and she used to work with me and had to have a huge amount of time off work. She said it was the most painful thing she's ever been through.
And again, it's one of those complex things because this virus lies dormant in your nerves, and once it incites in the nerves, nerve pain is one of the most complex things for us to treat. So a couple of Panadols don't solve the problem. And it was interesting, I saw a study in the US where they correlated incidence of shingles with opioid overdoses because people get to that stage where the pain is so bad, they start on opioids. So, again, these unintended consequences become more and more challenging as we try to string them all out.
Speaking as someone who declared my personal interest because this runs in my family, I'm always like, whenever there's a headline about dementia and Alzheimer's, I'm reading it. I'm trying to work out what I should do. And actually, I saw last night, just as I was going to sleep, Eric Topol published his latest Substack. And it was about a blood test that can predict Alzheimer's 20 years ahead of any symptoms, which sounds really cool. And apparently, that test isn't news. Like it made the news at the start of 2024, so over a year ago. But now it's commercially available in America for like $200. So if you're listening in America and you're concerned, talk to your GP. But here, Foley Institute and other places, they're still trialling it in Australia. So it's not available here commercially. But that's something I'm keeping an eye on as well. Eric was saying it shows pretty much almost 100% certainty whether or not those trial participants will end up with Alzheimer's disease pathology in their brains. And it's interesting that, isn't it? We've talked about 23andMe, the idea of information is power. Some people do not want to know. Like I can tell you with some of the stuff with my dad's health, he is like happy to be kept in the dark. He doesn't want to know certain things. Actually, my dad used to say, you don't go looking for trouble. And we're like, I don't think that's how science and the body works, Dad. I'm the complete opposite. I love the fact that I know because I feel like I have more control and more power. So I can make lifestyle changes for a condition that actually is heavily influenced by lifestyle. So there's no guarantee I will get it, but it's a constant. I think about it a lot. And it's the reason that I became a vegan over a decade ago, because I'm like, okay, what can I do? Diet, right, I'll do that. I still haven't fixed my sleep though yet, George. I'm still working on that.
Yes, I noticed that when I got that 3 a.m. message this morning. But look, again, this is a really important topic, and I think we can explore this in more detail, and maybe we can even get Eric on our talk, who knows? But I think there's some real opportunities here to understand all these things in context without causing too much anxiety or stress, but also, well-informed people. And the blood biomarkers are interesting. They've had an interesting history. I mean, Illumina had a company called Grail where they did a whole bunch of biomarkers and they decided that it wasn't a good thing and then they bought them back. So definitely food for thought and something possibly for a future podcast.
Yeah. All right, we'll get into it then. All right, we better get to our next hot topic. That was a good one though. Thanks, George. I always learn a lot from you. now we're going to move on to consumer tech and specifically wearables. Now, 3 stories caught our attention recently. The first, the Oura Ring, pulse potties that track health data with wearable tech. You might already own this wearable, or if you spend time in tech communities or others who are interested in quantified health, you would have seen others wearing them. I did see a heap of actually men wearing these when I was in the US last year at Health. Heaps of guys had them on. Now, this wearable has been around for quite a while, and users like its data tracking, particularly its advanced sleep analysis, and it has a readiness score that assesses how well your body is prepared for the day. To my surprise, I must say, George, that one showed up at my place this week, which I did not order. Ryan has wanted one for a while and thought he would treat himself, which is cool. But now Oura is making a big play in the femtech space, launching a research collaboration with Scripps Research Digital Trials Centre to study physiological changes during pregnancy. This is going to be really interesting. It's never been done before. You've got 10,000 Oura Ring wearers collecting data on what's happening in their body, and it could offer insights to all sorts of things. They're hoping to look at pregnancy-related complications such as postpartum depression, even risk of miscarriage and preterm labour. George, do you see Oura Rings becoming mainstream for pregnancy?
When the Oura Ring first came out, I looked at it and thought, the original one was pretty chunky, and I'm not really a jewelry wearer, so I thought, is this gimmicky? But you're right. I mean, a lot of my very well-informed colleagues in the US and around the world swear by them, and they seem to have capacity to pick up some interesting vital signs. It is interestingly that so many years later, they sort of realize, women's physiology is different to men's.
The science community is still, struggling with that concept.
Maybe in America now you can't because of the diversity exclusions that you can't actually, separate them. But I remember early going to a seminar many years ago where there were some very powerful female physicians sort of saying, you realize most clinical trials in the world have been done on men 25 to 45. And, we extrapolate the findings from those results to women in pregnancy. And so the fact that we're actually understanding the diversity of the population and women having babies is a key. If you look at the use of healthcare services in Australia, there's a little blip in between 20 and 40 where women use more healthcare services than they do before or after that, obviously related to things like pregnancy and that is related. Yeah. So I think this is a really important study. Kudos to them for making the effort to understand this. The questions of evidence come in, the sensitivity and specificity of the numbers they measure. Again, this following from the earlier story, correlation versus causation. All these sort of things require us to have very powerful tools to analyze the data. But the fact that we're actually looking at what is a very important phase in a woman's lives deeply and how we can leverage the technology to make that better is great. Worry that it may be a bit of a marketing hype thing. So I don't want every pregnant woman to be walking around with 12 different sensors on them to measure multiple things. And it is an anxiety-prone time of life. So making it the anxiety worse, maybe worse. But again, well-informed, properly researched, good evidence, all those sort of things lead us to having guidelines and information that people can use. And going to some of the earlier interviews we've had, good information enables good decision-making.
Yeah, no, absolutely. So we'll keep an eye on that story. And it's interesting because we talked about Eric Topol earlier and Scripps is where he is as well. So, yeah, very cool. All right. So also a consumer wearable story that caught our attention is the US FDA approved an Apple Watch app that continuously monitors for seizures. This could be a game changer in epilepsy care. The company, EpiWatch, which I believe spun out of Johns Hopkins, uses the Apple Watch to detect and alert for tonic-clonic seizures, otherwise known as grand mal seizures. The app reminds people to take their medication, provides insight on what triggers a seizure for them, and screens for depression, anxiety, and it allows for logging, of what's happening that could be related to when seizures come on for you. What are your thoughts on this one, George?
Well, first of all, I have to say an app that has an FDA 501k clearance is a big deal. And this is considered the nirvana of medtech regulatory approval. And the fact that this one has a very defined yet very important use case is great. Like you pointed out, it comes from a very reputable organization like Johns Hopkins. I think it bodes really well for the maturity of the sector. The more apps that go through this regulatory approval process demonstrate real clinical value and are then highlighted in the relevant app stores or even delivered in such a way that they're prescribed, I think is going to be a great thing. The one issue will be cost. I mean, it is expensive to get regulatory approval. And I don't know about you, but when I go to the App Store, I usually look for the free apps or the 99-cent apps. So the $150 app to monitor my epilepsy may be a challenge. So that raises the question of reimbursement. If this is going to have health benefits, and again, this is where we start doing health economic analysis, if we prescribe this app to someone with epilepsy and include it as part of the health insurance pack, we've been talking about digital therapeutics for a while now. We haven't really seen them take off, but these sort of properly approved evidence-based solutions that deliver value, I think are something we really need to start thinking about. And maybe our prescription pads will have a, tick, get for free on the App Store type box in the near future.
Yeah, let's hope so. The equity issues is what concerns me. So, I love the fact that tech is involved in healthcare and this is a successful startup that hopefully will be commercially successful. But what happens if you can't afford that app? What about if it's in the US App Store, but not the Australian one or the UK App Store? And because it's on the watch, you need to buy the watch as well. And I get the commercial models and I don't have a problem with that. I do have a problem with something that is deemed to be actually something that could save a life, help improve quality of life, all these things. And yet you can only get them if you can afford it. So thanks for raising insurance and those types of things, because it's something that insurers and governments need to become increasingly aware of, I think. Otherwise, we create this disparity that something that is good is only available for rich people, which is not good.
One thing we do well here in Australia through our PBS is that we provide therapeutics like some medications at a subsidised price, especially for those who can't afford them. So even though we know there's an election happening, so they're talking about making the maximum price $25, but for people with a healthcare card, they ultimately go down to almost zero in price. So we do that well. How we do that with technology, do we prescribe an Apple Watch and do we supplement the cost of it? And again, this is where we need to do the economic modelling to see how it all plays out. But this is yet another tool in the domain of helping people manage their diseases.
Our very first guest that we had on this show, George, was the Productivity Commissioner, Catherine de Fontenay. So I'm thinking this is something that the Productivity Commission could look into. Like, how do we actually cost for these things and reimburse them, the economic models around it to ensure that there's equity across the system. All right, now this is a big story, I think, but it hasn't happened yet. So this is a bit of us speculating here. Now, in the field of consumer wearables, the big news is that Apple's got a project named Project Mulberry. It's not yet released, but it is set to be released in 2026. Project Mulberry is effectively an AI-powered health coach, which will be integrated into the Apple Health app that comes on your phone. Now, George, the reason this story is interesting to me is that Apple have been saying publicly for many years now that they're planning to become a major player in the health landscape. Of course, they have so much money and people can be really fans of Apple technology. So there's been a lot of opinions put out there in public over the years about what would Apple do? Would they actually build hospitals or even primary care clinics? But as time has progressed, their play clearly is in the consumer space with an ecosystem of devices that people carry with them or literally wear them almost constantly, except when they're charging. Now, with the resources they have at their disposal, I am wondering if the wellness sort of health app tracking industry is set for disruption and even could it die out? Because will Apple just acquire or build all the good tech themselves and then integrate it? So as an example, many Pulse Potties will have MyFitnessPal. Even if you're not using it now, you've probably used it at some stage. It's an incredibly popular food tracking app. Hundreds of millions of people around the world use this and have a subscription. Brings in, I think, about $350 million of revenue every year. But with this new Apple Mulberry project next year, Apple's probably going to be doing food tracking and it'll do it natively for me in the health app that comes with my phone. I don't need an additional subscription and I'm certainly not going to need MyFitnessPal anymore. So I'm wondering, is Apple set to revolutionize an industry that they actually created? George.
It is interesting, isn't it? So jumping from, we talked about earlier about a single app that has a huge thing. We're talking here about an entire app platform that integrates health, and Project Mulberry is a fairly weird name, but I guess there's a fruit relationship there that we need to keep in mind. But going back to 2019, Tim Cook made a very interesting prediction. He said that Apple's greatest contribution to mankind will be about health. And this may well be that obvious steps in that direction. I mean, it's big. It is a big deal. Again, it's a announcement of a potential release. So, I mean, and this idea of a digitally enabled health platform is not new. I mentioned to you back when I worked at Intel, there was an Australian company that made one of the very first smartwatches called Basis. Great technology. The only problem was they had to stop making it because it got so hot it burnt people's wrists. But the idea was great. The idea was great.
Yeah. Ahead of their time.
Yeah. Intel acquired it for like $100 million back then and was trying to integrate it into things. And so we had all these wonderful videos of the fit young person running down the street at 5 o'clock in the morning and their watch beeping and they could look up their pulse and then they'd go to their smart mirror and it would tell them and their TV. And remember, this was before the iPhone existed. So they didn't actually get a thing on their phone because there was no such thing as a smartphone. They got an SMS telling them what their pulse was. So they were cute videos, you know. But the idea that integrating a whole bunch of little things together to maximize health was a good idea. Then you shift forward 20 years and look, it's becoming a reality. Lots of people use their smartwatch. I know my middle son, Manuel, has become quite an avid runner now, and he does a whole bunch of 5Ks and half marathons. And he relies on his watch to, measure his pulse and measure his pace and uses as part of a training tool. So those sort of things from a health perspective are great. And then we also seen opportunities where they can be used in actual healthcare delivery. The atrial fibrillation detection that's now available on iWatches and also on Samsung watches has really changed that model. I mean, atrial fibrillation was a ignored disease. Now I have people showing me their pulse monitors on their watches all the time. The only thing I would warn is that this big tech companies make these big announcements, make big promises, and then sometimes they sort of hit that President Trump factor. Back in 2017, someone who I don't usually quote, but I will quote President Trump here. Nobody knew healthcare could be so complicated. So as they try to do these sort of things, that brick wall of complexity that there are no single solutions out there and integrating it. But Apple have been doing this for a long time. Lots of interesting things, but they really keep them hidden until very late. They don't make announcements. And I will do a challenge here.
Okay.
The doctor at Apple is a guy called Dr. Sumbul Desai. Now, Google's Dr. Karen DeSalvo joined us a couple of podcasts ago, and she gave us a great discussion. So, Dr. Desai, come and join us at PulsePod and discuss what Apple is doing. We really want to be able to do this from an informed perspective, because if you guys can pull this off, then the world's going to be a very different place. And you're right. Apple was the first $2 trillion company. I mean, it has bigger than the GDP of some countries around the world. So this may be an opportunity.
Actually, there's only 4 countries, because I talk about this in some of the keynotes that I give. There's only 4 countries that have a bigger GDP than Apple.
So I reflect back on the 1980s when I looked at Apple stock and went, nah, who's going to want to buy a computer?
Oh, if only. All right. Well, I love the call out to Apple, and let's see if we can get them on, because I do think this could be such a game changer. There's like literally thousands, if not hundreds of thousands of companies out there, startups, building apps to track all sorts of things. I do wonder, because of course, to get an app in the App Store, you have to meet Apple's criteria, or in the case of, the other at Google Store as well, they have their criteria. None of the criteria actually assesses that your medical claims are accurate. So, which app helps me manage my diabetes? What are the pros and cons? What's their level of clinical efficacy? That's not measured, certainly not by these companies. So it creates a lot of confusion around which apps are the good ones and which aren't. But at the same time, when it comes to a company like Apple, and, I'm sure the other hardware players are looking at this space as well, like you mentioned, the other things that are integrated into Google's and Samsung devices, those types of things, that it could come a day where, I don't have all these health apps on my phone, especially the things that people mostly want to track, or you were just talking earlier about the pregnancy and the Oura Ring. Like, there's things that affect large quantums of people. If that's just integrated and it's part of the hardware, it's part of the software that comes with the hardware, and I don't need all of this, it could be a massive, massive disruption. But then Apple would be disrupting themselves, because they take, 30% cut, I think, off every app in their store. So maybe, that'll be an interesting thing to talk to Apple about, like what level of disruption they're going to make for themselves and their own sector.
Do they lose that 30% margin? Do they integrate it into the device? Are these devices becoming commonplace and available for $49.95 at your local grocery store in the future? Those are the sort of things that are big changes. It's an interesting time. Like I said, we live in interesting times, and you can't ignore Apple. They seem to really be powering ahead. But then it raises the question of interoperability, Does your Apple Watch talk to your soon to be Epic hospital system in New South Wales, or your best practice general practice system? So, or do you now need to buy the Apple EMR and the Apple GP system to integrate it all?
Yes. Well, the good thing is Apple at least uses Fire.
Yep.
Heading over to the UK now, we've recently spoken on the pod about the closure of NHS England and its merging with the Department of Health and Social Care that's happening over the next 2 years. Well, as you could imagine, there is a lot of people concerned about what this will do to the state of digital health initiatives and digital health BAU across the NHS. And of course, people are worried about their jobs. Well, Health Secretary Wes Streeting recently confirmed that the government is committed to retaining the digital health workforce despite the abolition of NHS England. And he said all the right things, noting how critical the right skills are to drive the digital transformation of the NHS. And then I also saw this other story, also in the UK. The government has further committed themselves to establishing the UK as a leader in life sciences and medical tech. The Prime Minister, Sir Keir Starmer, announced that his government, together with the Wellcome Trust, will invest up to £600 million to create a health data research service. The idea here is to provide a single access point to national scale data sets, transforming access to NHS data for researchers. Under the plans, clinical trials will be fast-tracked to accelerate the development of medicines and therapies, and with the time it takes to set up a clinical trial cut from 250 days that it is currently to 150 days by March 2026. And George, I was reflecting back on previous episodes, and in November last year, we talked on the pod about the Sudlow Review, which was called Uniting the UK's Health Data. Now, it would seem that the UK government has followed through with recommendations from the Sudlow Review, which is prioritising looking at health data as a national asset. Do you think this is good news for the UK? Will we see the same approach take off in other jurisdictions?
The announcement that job security has been ascertained for many of the digital health colleagues we have in the UK is a great thing, especially for our UK colleagues. Unfortunately, that means they won't come over here and help us, so we have to maybe make ourselves a bit more attractive. But having seen many politicians make many promises, I sort of don't necessarily hold the world's greatest respect for some of their announcements. However, having the Wellcome Trust involved as well is a great initiative, and I note how you love their libraries. They sound like they're a great organisation.
I do love their library.
I mean, the UK has been a world leader in both successes and failures of medtech over the years. I mean, the NP-FIT, the early 2000s, they were the first country to decide to computerise all their clinical records, and they hit that challenging wall of how hard it is. But, you know, they learnt a lot, we learnt a lot. We got Mike Bainbridge. It's all positive for us. Yeah, so it's a good thing.
That's right. It means you can take a holiday from the pod every now and again.
Yeah. Again, these are great initiatives. Hopefully, Australian government is watching and will announce some of these great initiatives as part of our upcoming elections as well. Delivering on them is the challenge, and that's where things become hard. And now the fragmentation of the world that we're seeing now with all these tariffs and whatever may mean that the UK and Europe may become a new focus. We've often focused on the United States as sort of the innovator. Things may change and other parts of the world may come in. If they can get clinical trials down from 250 to 150 or even better early next year, that's a great start. As I think I've commented earlier, my elder son now works for a drug company. They're doing a lot of trials, and the complexities of doing trials is mind-boggling. And a lot of it just comes down to access to data and being able to share data. So kudos to the UK. Anthony Albanese, Peter Dutton, if you're watching, similar announcements will go down well. I can guarantee you the digital health vote, there's a couple of hundred of us that should swing a seat or two, but it is important that we drive innovation in this sector. And that requires having people with real jobs and real career paths in this sector.
Well, that's what we saw in New Zealand, of course, with their budget measures, and got rid of a lot of digital health people there. So, yeah, it'd be really interesting to see. And I was thinking as well, we should reach out to Finland and get someone on the pod, because I did meet someone from Finland last year when where was I?
Somewhere in the world.
Did I go to Finland? I think I might have been in Finland. I went to a few places last year. Anyway, but apparently they have a very similar thing. So if you're a researcher and you need access to any sort of health-related data for your research, whether you're at a university or a pharmaceutical company or wherever you might be, there is one-stop shopping in Finland and, one ethics process. And if the UK can do this, and we've seen a lot come out from not just under Sir Keir Starmer's government, but also from the Tony Blair Institute about, pushing pushing the envelope around life sciences and medtech and positioning the UK as a global leader in this. So certainly getting the infrastructure to make those things happen is really critical. So if they can pull this off with their National Health Data Research Service, we'll keep an eye on it. It's a good thing.
And as a former colony, they will be gladly share it with us and we can do it together. I think there's an opportunity there. But yeah, as long as we keep the Union Jack on our flag, they can share some of their knowledge with us. So we'll have an opportunity. I think it's interesting because, again, you noted Finland. I met some people from Finland when I was in Barcelona earlier this year. And organizations like VTT, which is their CSIRO equivalent, does an amazing job in linking organizations together. The other thing, of course, is that we've seen now with the disbanding of the NIH and many various other things in the United States, there may be a whole English-speaking workforce who will start learning how to spell proper English and come over to the UK and work over there. So it's interesting times. I think it's a great time to be in digital health. I think we're recognizing that it's an important tool. And if Apple takes us all over, then I'm happy to work for Apple. If you need an old curmudgeon doctor, hands up. I'm happy to come and give a hand.
That's so kind of you, George. As long as you can keep doing the pod, because I need you. All right, well, look, it's time for a quick break. And when we return, we are going to be talking getting rid of the stupid stuff in healthcare with President of the AMA in Victoria, Dr. Jillian Tomlinson. Today on Pulse, we are joined by Dr. Jillian Tomlinson, President of AMA Victoria, a plastic and hand surgeon and someone who is deeply committed to making healthcare work better for the people who deliver it. Today, Jill's wearing her AMA hat and she's going to be talking to us today on a deep dive into all things gross. Yes, now GROSS is a key initiative she's championing with a pretty unforgettable name, the GROSS program, which stands for Get Rid of Stupid Stuff. It's a refreshingly honest and clever campaign to identify and eliminate low-value, frustrating or duplicative tasks in healthcare that get in the way of patient care. Now, we're going to explore how this idea, which started in the US, I believe, is being adapted for the Australian context and what it could mean for digital health, clinician morale and system reform. Jill, welcome to the studio. It's great to have you here.
It's great to be on the show. Thank you for inviting me.
Yeah, it is fantastic having the AMA talking about these issues openly, so we're looking forward to it.
Now, let's start with the name, GROSS, get rid of stupid stuff. I love it. But I believe it wasn't your idea, Jill. Where did that idea come from and what motivated you to bring it to Australia?
GROSS was first introduced in Hawaii by Melinda Ashton, a doctor who was inspired by widespread clinician frustration with redundant and inefficient tasks. And she produced great results at Hawaii Pacific Health. And we have similarly within the AMA seen a whole variety of unnecessary administrative tasks that just weigh doctors down, detract from patient care, and we thought that that would be a great initiative to bring to Victorian Health Services so that we can try and get rid of all of that stupid stuff.
Excellent. And when did you start this program in Australia?
So we launched our campaign calling for it to be endorsed by government and introduced into all of the healthcare facilities in Victoria or the public hospital systems in the last month. And it was actually introduced in Western Health in May 2024, and it's also been introduced in Queensland as well previously. So it's not the first time it's been on our shores, but we are certainly really keen to ensure that across Victoria we get behind it and we get rid of the stupid stuff.
So burnout for clinicians has been a major issue for a number of years, and we understand that there's lots of stupid stuff that happens in admin, in financing, but also in clinical care. So we're focusing in on the entire gamut of care from the front desk all the way through to operating theatre?
Absolutely. It is across the system. And one of the great things about GROSS is that it is empowering clinicians. It's clinician driven. So it is not that CEOs identifying what the stupid stuff is. We know that the people who are actually undertaking the processes are best placed to identify where the inefficiencies lie and what can be done to improve them. So in terms of where it is in the system, it is everywhere, and we would like it to be in every Victorian hospital.
Cool. Some real world examples of what sort of stupid stuff you've come across up to now?
Oh, and just keep in mind, this is like a 1 hour show, Jill. So don't give us all the examples.
Right, okay. So the one that we have identified as the first thing that we would absolutely love to just get rid of in Victoria is the duplication of mandatory training modules. Now, it is not uncommon in Victoria that doctors work at multiple different health services. And while it's great that we have multiple different health services, it is not great. The doctors who work at different health services have to do those mandatory training modules at each one, and they can be exactly the same. So you have to do your hand hygiene at the Austin, and you have to do your hand hygiene at the Eastern, and you're also working at St Vincent's and you have to do it there. And then there's the infection control, the protective equipment ones. There are so many modules, and the unfortunate thing about the modules is not only that there's duplication, but also that they're relatively low value. They're for compliance often and not for education. And while we're also keen to address the low value aspect to the mandatory training modules, we think that the duplication of the training modules is something that should be really quickly addressed and eliminated.
Oh, yeah. Oh, my God. One of the things, Jill, that I do is I work with Seeker Lab, and we teach clinicians how to be intrapreneurial and entrepreneurial. So the people who come along, they usually share those common frustrations. I was just the other day with these guys at Seeker Lab, and they were talking through different problems they might like to address, and that came up. And I had no idea. And they mentioned specifically the hand hygiene one and how long it takes, and doing it at multiple hospitals, and also that they have to do the same thing every year. It's like, well, has the science changed of hand hygiene? So I think from what I heard in that group, they would love to see this be way more efficient and be able to use their time in better, more productive ways.
Absolutely. And, hand hygiene is really important. The question of whether the hand hygiene module is actually influencing behaviour is another aspect to, what is the point of doing this? Because if you did know that the hand hygiene module wasn't changing behaviour, and say, well, what's the evidence in actually having every staff member do the hand hygiene module every year? We actually have to take a practical approach to these mandatory training modules.
I would be fairly confident that doing it 7 times doesn't necessarily improve the compliance anymore.
Absolutely. And the assumption that you usually take is that if the solution is education, then the problem is a lack of knowledge or ignorance. And I don't think that there is ignorance about the value of hand hygiene.
So we know that digital tools have been introduced into most healthcare systems nowadays, and we've seen some stories coming from around the world, including Australia, around how they've actually added to the clinician's workload rather than reducing them. Where have you seen digital tech actually create more challenges or more friction? And are some of the digital tools stupid stuff?
Well, it's entirely possible for the digital tools to be stupid stuff. We've all completed forms that have mandatory fields where you think, oh, okay, well, I didn't realize I have had to put something in that field, but let me put something in there. The actual design of the system that you work with, and of course, the user experience. So does it actually make it easy to use? Is it leading you down the right path, or in fact leading you to the wrong path? All of those things can both be inefficient. They're also at times implicated with patient safety, which is another aspect of it. I suspect that if anybody has ever received one of those really long discharge summaries that has, 3-month ICU stay, copied and pasted all of the blood tests, even just, having to scroll through to get to maybe find a report, the way that digital systems allow that duplication or proliferation of information can be a problem as well. So the example in Hawaii that was really crucial was nurses had been asked to document their hourly rounding, and nobody was quite sure what the purpose of documenting this hourly rounding was, and it was, I think, taking 24 seconds per patient to document. So once they removed that requirement to document that 24 seconds per patient every hour, actually introduced, the equivalent of, I think, 11 full-time equivalent nurses for those hospitals. And of course, importantly also, I'm pretty sure those nurses were really keen that they didn't have to be clicking those things. The way that we use the digital tools can be improved, and GROWS is about empowering clinicians so that we can actually raise those concerns and know that they'll be addressed, and know that people want us to raise those concerns and that our opinions on the systems that we work in are valued.
And Jill, how do we go about avoiding that mistake? Like, is it a part of the very design of the screens and what you click, but then also I imagine it's in its implementation within different facilities?
Yeah, so there's implementation in different facilities. There is, I guess, the ability of some software to be modified is, sometimes it's possible and sometimes it's not. Sometimes it's an easy fix and sometimes it requires the next iteration, or we could consider that in the redesign in 5 years' time. The fact that we are considering growth at all levels, even whether that's having to physically take a piece of paper somewhere, because in this hospital it's paper-based rather than actually having electronic digital systems. And the reason we're considering growth in non-digital systems is about a third of health services in Victoria don't have an electronic medical record. They don't have the digital maturity for, in fact, the problem that we're talking about, which is that digital clutter. Yeah, there's a lot of different ways that efficiency can be improved in our health services. And as we move increasingly to digital systems, it's, I think, really crucial that we all recognise that we can have iterative improvements to make the digital systems better, so that people are not saying, well, actually digital systems made my life worse. They created burnout. They meant that there was a computer between me and the patient. We want to put patients at the focus of what we're doing, and we want to ensure that we're bringing in technology. It's better for everybody, better for patients, better for clinicians, and using it as to its fullest extent.
I think also just having a process for clinicians to get that feedback into the system, because in the past we would huddle around the flight deck and complain about it, but it never got to where it needed to go. So I think that's a great initiative.
Absolutely. And I think even sometimes just knowing who your chief medical information officer in the hospital is and having an approachable one who can fix things. I personally, when I can get things fixed, I think this is amazing. This has made my day. My gosh, I don't have to do that anymore. It's fixed. It's addressed. And, if we can amplify that across the state of getting all of those challenges fixed, that would be amazing.
Yeah. I'll give you an example. Someone told me the other day, and she's a chief clinical nurse at a hospital, and just this crazy stuff. She showed me a picture. So the workstations on wheels, which for our listeners who haven't seen them in a hospital, it's just basically a little table on wheels that has a computer on it and you can move it around to different wards, that sort of thing. Anyway, they're very common. And so apparently this problem had been going for ages and it finally got escalated to her. The problem was that the monitor, the way it sat on this workstation on wheels, the bottom of the monitor you couldn't see because it was like in the table. So a lot of the buttons you needed to click at the bottom of the screen, you couldn't get access to them. So she called the IT department and had it fixed. And I was just like, how long had that been a problem? Like, who designed these units? Who are there others who put them? Because it wasn't broken. It was literally designed that way and how it was put together. Anyway, I thought that would be a great example of stupid stuff that shouldn't be happening.
Absolutely.
Well, it's interesting because also in the frustrations of all those small, stupid things that happen during the day are enough to really make your life complex and difficult. And we already see the challenges we have, even with junior medical officers, but all the way through the system, keeping them in the system. One of the things you've said about documentation in particular is that it needs to be accurate, brief, and concise, which is, doesn't necessarily describe the way many of our clinician colleagues document. What can we do from a tech vendor and from the health system perspective to get that as a core goal for going forward?
It's difficult because I know sometimes there is enthusiasm for creating lots and lots of information, and sometimes the detail is important. But in most times, if the amount of information that comes with an individual patient actually requires an hour to sit down to read it, that's actually inefficient for their care, and it is creating significant problems. So being able to have ways that we can have the headline information, that we can have summaries. Some of it is also about how it's presented on the screen so that the information that is crucial and important is immediately available. Information about allergies, for example, and critical things like that needs to be front and centre. And information about what happened when they tripped over 30 years ago and got a graze on their knee, if it isn't relevant for their care, we don't need to be burdened by that level of clutter.
Yeah, absolutely. So digital and data can also help. What role do you see for well-designed digital tools and better use of data in helping us to reduce this administration burden, but also streamline care and effectively get rid of stupid stuff? So how can digital help?
It's important that we both measure how we're implementing growth and measure the time that people are spending on tasks and the improvements that actually can be created through the initiatives that we can implement with growth. The number of unnecessary forms and approvals is the data side of how do we measure the impact of growth. I also would anticipate that we'd get improved clinician satisfaction and enhanced patient experience metrics if we were to actually analyse the amount of time that doctors are spending on administrative tasks, and often it's 50% of time, and think, well, what opportunity cost does that have? If you were to add up what amount of time is spent on a duplicated mandatory training module, and we are not seeing a massive improvement in productivity. So measuring what we think is the workflow of a doctor and how that can be improved versus the actual output.
And you said like 50% in admin. And I know the figure that often gets quoted in the health informatics circles is that people feel generally that at least 30% of their shift at the hospital, regardless of your clinical role, is spent in duplicative administration tasks that don't need to be done at all, really, or could be done by somebody else, or they're looking for stuff. Like literally looking for things that can take 30% of the shift. And we know healthcare budgets are under significant pressure. That's not going to get better anytime soon. This is a global problem. So we've got those healthcare budgets that are stretched. And then we think, well, healthcare is unsustainable. You've just got to do more for less. The paper, which I'll put a link to it in the show notes, that a group of Australian researchers authored, shows that 60% of everything that we do in healthcare, it's a really good idea. It helps people. It's doing what we're supposed to do. But 30% is a waste of time. Like it could probably fit in the stupid stuff barrel, but then 10% is actually harmful. And that's not any fault of the clinician. It's because the systems aren't designed to actually put patient information where it needs to be so the clinician has access to it, those sorts of things. So there's lots of opportunities for digital to address this 30 and 10% of time that is wasted and shouldn't be done.
Absolutely. We've got to empower clinicians to be able to call that out and make change.
I'm glad, Louise, to refer back to the paper by Jeff Braithwaite and the team at Macquarie. And here in New South Wales, we're seeing a significant challenge. We've got junior medical officers on strike because they're working hours that aren't practical because a lot of the time is being wasted. I guess one of the key challenges we face in healthcare is the culture that we tend to just work our way through it, making sure our patients get high quality care. How do we empower clinicians to call out these inefficiencies or low-value processes early? How does an intern who's filling in the same form 13 times for the same patient point out to the right people, this is a waste of my time and energy?
I think our senior leaders play a crucial role in setting the tone for change, because when the leaders are actively supporting something like getting rid of stupid stuff, then doctors feel empowered to report the inefficiencies that they see without fear of backlash from the system and from those leaders. So we need our leaders to be willing to listen, to act quickly and to remove the barriers to implementation. And we see that growth thrives in an environment of psychological safety. If people feel safe to speak up, then we can normalise the act of questioning the existing processes. We can also celebrate the improvements. And we've got to move to a point where the phrase, we've always done it this way, is no longer an acceptable response to a question of why are we doing this, particularly when it is clearly stupid stuff. Duplicative training modules are an example that everybody agrees is stupid. So let's do something about it. Our ask is for government to commit to it, to appoint a high-level champion, so perhaps the Secretary of Health, and for it to be embedded within each health system and actually put as part of the statement of priorities for each health service. Research behind growth has shown that if you have that strong leadership support, then yes, people do feel empowered. We are wanting to really make sure that every healthcare dollar is spent where it is most needed on patient care. Doctors want to identify those inefficiencies, fix them, and just create a much better system for us all. the vision of a system where every time that there is an inefficiency and you work out how you can fix it, that it gets fixed. That to me is a system that I want to work in and that excites me and makes me want to go to work.
Yeah. And that's what we need, more clinicians feeling that way every single day.
Absolutely.
I guess ultimately clinician satisfaction. I mean, the happier clinicians lead to happier healthcare providers.
Absolutely. Clinician satisfaction, retention in the job. Yeah, I think that's huge.
Excellent. And what's your vision for growth? What does success look like for you on this?
My vision is a healthcare system where clinicians are free to practice medicine without unnecessary administrative burdens, where technology works seamlessly to support care delivery, where patients are able to receive more attention and personalised care. Their treating clinicians have got greater professional satisfaction. So growth is a really powerful step in realising that vision, and it's within our reach. So hopefully we make it happen.
So finally, for the Pulse Potties listening in today who are really keen to learn more and they're probably, on a walk or doing some housework, listening to the podcast and yelling in agreement at their phones, like, yes, I want that. How can I get involved? So what do they need to do to get involved and how can they raise the red flag on this stupid stuff in their own workplaces?
So, well, in terms of supporting the call for growth to be implemented in Victorian Health Services, we have a petition at megaphone.org.au/P/AMAV. And so everybody is welcome to sign that, share that. There's also information online in New England Journal of Medicine about GROSE's initial implementation, and there's a toolkit as well as to how you can implement GROSE and what the learnings have been from those who did. And I'd also encourage everybody to, if they're finding themselves with digital clutter, reach out to your Chief Medical Information Officer, find out who it is that actually might have the power to resolve your problem, get interested and informed about how these problems arise, but also how we can solve them, and never stop questioning why is it that we are doing it this way and how can we make it better.
Excellent. I will put links to all of those resources in the show notes. Jill, thank you so much for joining us. It's really inspiring to see that under your leadership, AMA Victoria really taking a stance on this and being out promoting something that's so positive for the health service, which will, if adopted widely, will make such a difference to clinicians every single shift, every single day. And of course, it'll make a really positive difference to patients as well. So thank you for your leadership.
Thank you, and thank you for allowing me to talk about growth. And yeah, we really need it to happen, and I'd love to see that as an outcome.
Fantastic. We keep on hearing about the need for more clinicians, but if we can actually remove some of those burdensome tasks that allow clinicians to do what they train to do, I think we'll have a much better and much more efficient healthcare system. Thanks again, Jillian.
Thank you.
George, I'm such a big fan of getting rid of the stupid stuff. What do you think?
There is so much stupid stuff in healthcare. It's ridiculous, isn't it? If you speak to any junior doctor, they'll tell you that half of, not more, of their day is taken up doing stupid stuff that could be replaced by a simple AI agent that would send the information around to the right people at the right time. So I think this is a great initiative, and they're starting from the grassroots, and they're doing stuff that isn't all technology. But again, this is where technology can play a role. We can replace the stupid stuff. So I take my hat off to Jill and her team on getting rid of it. And I look forward to the loss of stupidity in healthcare.
Yeah, no, I think it's a great program. So we'll keep an eye on that. And especially if we see the Victorian government does take it on board and start putting it through hospitals. I've been doing some work with hospitals recently, and I'd mentioned the program to a couple of people and they hadn't heard of it. So I was like, all right, I'm sending you links, and listen to the next episode of the pod where we'll be talking about it. Anything we can do to promote and help that. And I love the fact digital health is not coming off unscathed as well. Like, a lot of it is, not introducing digital processes that make things worse for people and add to the duplication. We should be utilising digital and data for good, not evil.
Absolutely.
Yeah. Well, George, do you have any recommendations to end up the show?
I've been watching a TV show called Brilliant Minds. It's a medical drama inspired by the writing of Oliver Sacks, a neurologist who wrote some interesting books a couple of years ago. And it's about a neurologist who's fairly quirky, and he has a couple of issues. But one of the early storylines which caught my attention was a guy who had locked-in syndrome. and they implanted a neural link type device, a brain machine interface into this guy. And I won't ruin the story, but there was some really interesting twists to the story. I think it became a good. So I do love a good medical drama.
I'll watch that.
Yeah, highly recommend. It's quite good. What about you?
Oh, thank you. I've read that book with the guy with the locked-in syndrome, which is really good. So I'll be interested to see the show. And I haven't watched it yet, but on my viewing list, because my doctor friends are telling me I have to watch The Pit, because apparently have you seen that? Apparently that's really good. They said it's like too close to home for them. Like it's like their days.
I started watching it when I got back from Singapore. So Marina and I love to binge watch. We sit down and we watch a series from end to end. And remember the good old days when you watched something on Wednesday, then had to wait till the next Wednesday to find out what happens?
Such a boomer, George.
Gee, how did we ever do that? What can you recommend this week?
I can recommend, and I will put a link to it in the show notes. It's a report. Sorry, not as cool as TV, but still cool if you're in the digital health space. So And Health, they've released their latest report, which is called Rising Giant. Now, their State of the Industry report for digital health startups reveals 52% compound annual growth rate in digital health sector since 2019, with over 1,000 digital and connected health companies. So it's a really interesting report, and it's really well put together. There's pretty graphs, and I think it's a really useful tool to promote the sector and the need for sustained investment as well. Have you had a chance to have a look at the report, George?
I have, and I read their previous report, which was the sleeping giant.
Yes.
So the sleeping giant is now the rising giant, and I guess it's great that we actually consider digital health to be giant. I mean, I guess it's all relative in size. I agree. Good data points. Doesn't quite reflect what my experience has been. So I think it's maybe a little bit overly optimistic, but hey, I do note that the company Lenexa, who I commented on earlier, was part of the And Health Accelerator, and they won that award in Singapore. So there are some success stories there. I think we just have to be careful we don't overhype the industry, and keeping in mind from 2019 to now, there was that pandemic thing in the middle, which sort of twisted the results a bit. So the things it calls for, we've been saying for years, more money, more support, support for procurement, all those sort of things make a lot of sense. I think we need to make sure we can deliver on those. And again, in the context of what we discussed earlier, we do this within the context of the global picture.
Yes. Yeah, absolutely. All right, well, we'll put a link to the show notes. So you guys all have homework to do. You can have a look at the And Health report, and you can also watch some TV shows that George and I have recommended.
And if you want to read another book about giants, my favorite book to read to the kids was the BFG, the Big Funny Giant. So that's a good giant book as well, including in your agenda.
All right, have you introduced it to Evie yet?
Not yet. She's a little bit young to understand the concept of a giant, but we'll get there.
Okay, well, I want to see pictures of her in her Easter outfit, whatever that is going to look like, George. So send them through.
Oh, shall do.
Well, have a lovely Easter. And in the meantime, could you please read us out?
Thank you. And to you too, have a lovely Easter. And if anyone happens to be near a Greek church on Friday, join in the festivities. Pulse is produced by Ivan Jurek of Octopod Productions and is brought to you by Pulse IT News. Big thanks to everyone for listening. Make sure you subscribe, follow and rate us wherever you get your podcasts. And don't forget you can visit pulseit.news to sign up for the e-newsletter and explore Pulse IT's massive digital archive. Send any feedback or topic suggestions to pulsepod@pulseit.news. We'd love to hear what's on your mind.
Thanks, George.